Assalamu alaikum. I'm Dr. Matiullah Khan. I'm consultant endocrinologist at Shifa International Hospital. Today, the topic of discussion is primary aldosteronism. So, what is primary aldosteronism? So, basically, this is the autonomous production of aldosterone at the zona glomerulosa, either by hyperplasia of the gland or by adenoma. So, aldosterone is produced autonomously, and this is dysregulated production. And the angiotensin 2 and renin are actually suppressed in this case. And we also know that basically the sodium absorption at the level of proximal convoluted tubule and the loop of Henle distal convoluted tubule is done by this angiotensin 2. When aldosterone is so much high and that aldosterone is autonomously produced, then it will cause reduced renin, suppressed renin, and that causes low angiotensin 2, and therefore there will be no absorption of sodium at this level. And this will lead to an increased distal sodium delivery. And then in the principal cells, the aldosterone will act on the mineralocorticoid receptor that will produce more ENaC channels that will reabsorb sodium from the principal cells. And in the principal cells, with this sodium reabsorption, there is also excretion of potassium ion. And in the intercalated cells, there is the excretion of hydrogen ion. So basically, this leads to a vicious cycle that has CV sequelae, this distal sodium delivery, and then the reabsorption of sodium, volume expansion, blood pressure, and in turn, the excretion of potassium and hydrogen ion is a vicious cycle. There will be more and more sodium reabsorption that will cause more and more sodium delivery distally, and that will be reabsorbed, and so on and so forth. So basically, what is primary aldosteronism? This is the inappropriate, relatively non-suppressible renin-independent aldosterone production. So renin will be low, renin will be suppressed. It will not be dependent on the renin. There will be autonomous production of aldosterone. And this not only results in the activation of the renal mineralocorticoid receptors and all this vicious cycle that we discussed that leads to blood pressure, potassium excretion, hydrogen excretion, but it also causes an increase in the cardiovascular disease independent of the blood pressure. That's the most important point. This is because of the extra renal mineralocorticoid receptors that are present all over the body, on the heart, the vessels, and everywhere. So that we will discuss further. So basically, clinical manifestations, so this reflect the severity and duration of the renin-independent aldosteronism. Blood pressure and potassium are the dependent features. So the hallmark is, again, I'm emphasizing on this, there is suppression of renin and there is inappropriate dysregulated production of aldosterone. So in a nutshell, if anyone asks us what is primary aldosteronism, so this is a renin-independent aldosterone production. This is the principal mechanism that is going on, that there is inappropriate, non-suppressible aldosterone production, and there is suppression of renin because of this increased ECF volume. Now, we know that when the ECF volume is increased, renin is suppressed. This renin suppressed should result in a low aldosterone, but there is autonomous production of aldosterone, and that is independent of it. This then leads to volume expansion, inhibition of angiotensin 2, and sodium reabsorption, potassium excretion, and all that. But remember one more thing, that this is not hypertension with hypokalemia. In fact, the normocalemic hypertension is the most common presentation of primary aldosteronism. As per William Young, all patients with hypertension should be tested at least once. But at least if we follow the primary aldosteronism guideline of the Endocrine Society, they say that at least the sustained hypertension of more than 150 by 100, resistant hypertension, which is defined as blood pressure uncontrolled despite 3 drugs, including a diuretic, hypokalemia and hypertension, hypertension and adrenal mass. When you are doing the workup of adrenal acidentuloma, then you have to rule out primary aldosteronism if the patient has hypertension. A family history of relatively early onset hypertension, strokes, or other CV morbidities. Hypertensive in a first degree relative of patient with primary aldosteronism, and then sleep apnea. So at least in these patients, we should do, but William Young says that at least once it should be done for every hypertensive patient. Now, this used to be thought that it is a rare disorder, but this is not rare. This is very common, and one of the most common endocrine hypertension and one of the most common secondary hypertension. Around the prevalence is around 10% or more than that. So we start with this case, a 49-year-old man with hypertension for 10 years, several episodes of hypokalemia on 3 drugs, including on 2 drugs, amlodipine and enalapril. Patient had hypokalemia and hypertension, so this qualifies him for this aldosterone workup. So what is the prevalence? 5 to 10% in patients with hypertension and 15 to 20% in patients with treatment-resistant hypertension. Why do we care? We just can manage the blood pressure, and if there is some issue in the potassium, we can manage that. Why do we care so much? We care because it has these extra renal mineralocorticoid receptors all over the body, and especially it has cardiovascular morbidity and mortality. So we know that these receptors are not only in the kidneys, the late distal tubule and collecting duct that causes the sodium reabsorption, potassium excretion, volume retention, but it is also present in the glomerular mesangial cells, the CV system, the endothelial, vascular smooth muscles, cardiomyocytes, and also in the macrophages, adipocytes, fibroblasts. That results in fibrosis, inflammation, endothelial dysfunction. So this leads to remodeling in the cardiovascular system. And that we know from the heart failure trials that it has a role in reversing all these remodeling changes in patients with heart failure or ischemic heart disease patients. So primary aldosteronism is associated with increased cardiovascular and metabolic diseases that include stroke, kidney disease, diabetes, LVH, ischemic heart disease, atrial fibrillation. All these are increased. The odds ratio are written over here that when you compare the primary aldosteronism patient with the same counterpart hypertension patient, the blood pressure is controlled in both of them to the same degree. Still, there is more stroke, coronary artery disease, AFib, heart failure, diabetes, metabolic syndrome in patients with primary aldosteronism. So again, I emphasize on this that these are the classic indications for screening: severe or resistant hypertension, hypertension with hypokalemia, hypertension with adrenal mass, hypertension with sleep apnea, hypertension with a family member of primary aldosteronism. But the guidelines, unfortunately, are not followed by physicians. And maybe the reason behind that is that we have made in the past it very difficult to go for the screening of aldosteronism. So in this case, because of the hypokalemia and hypertension, we have done the aldosterone. The aldosterone is 30 nanogram and the renin activity is low. So does this confirm, or should we do the confirmatory test? What is the next step in the management? So should we perform oral salt loading, saline infusion, which are both the confirmatory tests, or should we repeat this aldosterone and renin after discontinuing the ACE inhibitor for 1 week? Or should we directly go to the abdominal CT for localization, or what? So for that, we have to go to the Endocrine Society guidelines. First of all, patients with hypertension that are at increased risk of PA that we just discussed, they should undergo the case detection by measuring the plasma aldosterone concentration and renin concentration, direct renin concentration. They should be done if the aldosterone is more than 10 and renin is suppressed. This makes it a screen positive patient. Then you should go for the confirmatory testing with oral or IV saline salt loading test. That confirmatory test, if it confirms it, like for example, in IV saline infusion, if we give that, basically we give 2 liters in 4 hours and then measure the aldosterone. If it is still 10 nanogram and above, that confirms it. If it is less than 5, this excluded. If it is between 5 to 10, then this is the gray zone. But probably it may have this hyperplasia that leads to primary aldosteronism. But somehow, once we confirm it, Then we go for the localization that we will discuss later as well. And after CT, even we go for AVS. We will discuss this as well. But there are some cases of the case detection when the aldosterone is very much high. For example, if it is more than 30, frank, marked aldosteronism with hypokalemia and renin suppressed. In these patients, we can directly go to CT. We don't need any confirmatory test. Like in our patient, there was hypokalemia and renin was suppressed, aldosterone was 30, so we should directly go to CT. Now, William Young has made this a very easy approach for the case detection of primary aldosteronism. So when to consider testing, he said that all patients with hypertension should be tested at least once. The case detection is basically very simple morning sample in seated ambulant patient. Plasma aldosterone concentration is measured and then the plasma renin concentration. If plasma aldosterone is more than 10 or it is more than 270 picomole and renin is below the lower limit, you don't need to go to the ARR ratios and all that. Just if it is more than 10 nanogram or more than 270 picomole and renin is below the reference range, this makes it a screen positive. Screening test is done, then you go to confirmatory. Confirmatory test, if spontaneous hypokalemia is absent only, then we do. Because if the patient has spontaneous hypokalemia, you don't even need any confirmatory test. And that is also important that in those patients with spontaneous hypokalemia and very marked aldosteronism, we should avoid confirmatory test because in that we have to give high salt load that can worsen the hypokalemia and have complications. But in the other cases, we can either do 4-hour saline infusion or we can do the 24 hours urinary aldosterone concentration. Aldosterone is measured for 24 hours in someone in whom we give sodium load for 3 days. Daily, we have to give 12 gram of sodium chloride in the form of broth or whatever we give that sodium for 3 days, and then we measure this. Okay, so in this patient, confirmatory test not needed and primary aldosteronism is confirmed. So the next step is abdominal CT. Abdominal CT done, no adrenal adenomas, but there are micronodularities mild bilaterally. Now, the subtype classification is important. Is it aldosterone producing adenoma, which is basically around 1/3 of aldosteronism is due to aldosterone producing adenoma. They are usually small, less than 2 centimeter, and primary aldosteronism in them is very severe. Okay. Bilateral idiopathic hyperaldosteronism can have a normal adrenal CT or there may be bilateral micronodular hyperplasia. Then we have 1 to 2% of cases of unilateral hyperplasia as well. And then the rare familial hyperaldosteronism, which is the glucocorticoid remediable aldosteronism, and very rarely aldosterone producing carcinomas as well. So the two important ones are aldosterone producing adenoma and bilateral idiopathic hyperaldosteronism. For them, we usually do the adrenal venous sampling. In this case, we should go for it because this diagram explains it. Whenever we do the CT scan, if the CT scan shows normal or micronodularity or bilateral masses or atypical unilateral mass and the surgery is desired, you have to go for adrenal venous sampling, whether that will be lateralized or not lateralized. If it is lateralized, you go for laparoscopic adrenalectomy. Otherwise, you go for medical therapy. If the patient even has hypodense nodule, which is more than 1 centimeter and less than 2 centimeters, this is very typical of aldosterone producing adenoma. But if the patient, even if the patient desires surgery, but the patient is more than 35 years of age, you need AVS because you have to be sure that this is not an incidentaloma. But if the patient is less than 35, there's marked primary aldosteronism, and the size is 1 to 2 centimeter, you can directly go to unilateral laparoscopic adrenalectomy. And again, if the patient is not desiring for any surgery, you don't need any further workup, whether the CT scan is normal or not. In both cases, you have to go for the medical therapy. So in a nutshell, adrenal CT cannot distinguish between AP and bilateral disease In majority of cases, in 60% of cases, it can distinguish, but in 40% to 45% cases, you still will need adrenal venous sampling. And this is almost always required, except this exception of less than 35 years age, marked primary aldosteronism, unilateral macroadenoma with normal contralateral gland. AVS is technically difficult and highly dependent on radiologist's expertise. This is just a diagram showing this catheter going from the femoral, and this is directly from the IVC by a 90-degree angle. It is angulated towards the right adrenal. The right adrenal is coming off directly from the IVC, and this is difficult technically to cannulate the right adrenal. The left one will be going to the left renal vein and then coming out of that, which is a bit easier. Here you can see the diagram. This is the left renal vein and left adrenal vein coming out of here. And from the IVC directly, the right adrenal vein is going directly into the IVC in a 90-degree angle. So you have to catheterize. The first thing is successful catheterization. Once you catheterize, you take the samples from 3 different places. The samples are basically cortisol, aldosterone, and these are taken from the IVC, from the right adrenal vein, from the left adrenal vein. The first step is always the successful catheterization, and that is when you compare the cortisol gradient of adrenal to IVC, the right adrenal to IVC, the left adrenal to IVC. This is called selectivity index. This should be more than 5:1. This is the first step. Here you can see the right adrenal vein cortisol is compared with the IVC, and the left adrenal vein cortisol is compared with the IVC cortisol. And both of them are markedly elevated, more than 5:1 ratio. This is the first step. This is important because if there is no successful catheterization, then this will be difficult to interpret, although there is an exception to that as well. Number 2, the second step is aldosterone to cortisol ratio, and this is called the cortisol corrected aldosterone. The cortisol corrected aldosterone on the IVC, the right adrenal vein, and the left adrenal vein. This is plotted. Next step is lateralization ratio. Lateralize to the left or to the right. Both of them are compared. From here, you can see the left adrenal vein aldosterone to cortisol ratio is compared with the right adrenal vein aldosterone to cortisol ratio, and the ratio should be more than 4:1. According to the Mayo data, this is basically usually the mean is 18:1 ratio. And the bilateral disease is when the ratio is less than 3:1. And in between is the gray zone. But the mean of bilateral disease is 1.8:1. And the last step we do is basically to see the contralateral suppressive index, CSI. When you compare the contralateral side with the IVC, it should be less than 1. And the lesser it is, the more it will show that this site is dormant. Like, for example, if it is less than 0.5:1, when compared with the IVC, this shows that post-operatively, this adrenal gland, and the opposite, the main adrenal aldosterone producing adenoma is removed. This one will be dormant, and the patient will rather develop then hyperkalemia for a short period of time. Okay, so this patient underwent adrenalectomy, left adrenal hyperplasia was diagnosed, and post-adrenalectomy, we have to see the aldosterone, and that is undetectable, and it is cured. So that we will discuss that what are our goals of treatment after that. So case number 2, 59-year-old man with hypertension for 20 years, hypokalemia. Here you can see patient is on 3 to 4 drugs, including eplerenone. What is the next step in the management? Stop eplerenone for 6 weeks, then test for primary aldosteronism. Stop lisinopril, test for primary aldosteronism now, or what? What should we do? So important point over here is the medications and their implications for the diagnosis. The antihypertensive medications can cause false negative results in mild primary aldosteronism. False negative, जैसे कि patient को होगा मगर result नहीं आएगा, which means कि क्या होता क्या है basically, because of these drugs the renin may go slightly up, जिसकी वजह से आप अगर रेशो निकालते हो तो वो रेशो कम आएगा. बट इफ यू टेक द एल्डोस्ट्रॉन इटसेल्फ, वो कितना रेज्ड हो रहा है, तो यूजुअली एल्डोस्ट्रॉन ज्यादा ही होता है इन पेशेंट्स में, एल्डोस्ट्रॉन लो नहीं हो पाता है. जो रेनिन है वो अगर किसी का रेज्ड हो, दिस मे बी फॉल्स नेगेटिव एंड यू मे गो on repeating without these medications. But in most cases, you don't need. So they do not cause false positive results. False positive नहीं करेगा. आपने एल्डोस्टेरोन का 10 to 15 कट ऑफ रखा हुआ है और ये सेकंड पॉइंट है कि रेनिन सप्रेस्ड हो. No drug will do that. No drug will do that. The drug may increase rather the renin कोई suppress नहीं करवाएगा, except beta blocker may suppress it, but कोई और ऐसा नहीं करेगा. First, we always do on whatever the patient is, on whatever drug the patient is. We see if the renin is suppressed, you can proceed to the case detection test, to the confirmatory test, to AVS, to anything. But if the renin is not suppressed and you have a high index of suspicion on primary aldosteronism, at that point of time, MRAs should be stopped for 6 weeks and then the patient is repeated. So remember, okay to perform while on any antihypertensive, and okay to perform even this confirmatory test on any antihypertensive. So test for primary aldosteronism now. This is another case of 52-year-old man with hypertension and hypokalemia. So the sodium is 147, potassium is 3.2, aldosterone is 24, renin is suppressed. We directly go to the CT because there is no need of confirmatory test in someone who has hypokalemia, suppressed renin, and aldosterone more than 20. CT scan is done, and in that we see adrenal demonstrates normal appearing gland. Now this, you may miss a small adrenal aldosterone producing adenoma if we go on this CT scans finding. So therefore, anyone who is above 35, we are considering surgery, we should go for AVS. So he undergoes AVS. The first step in AVS again is to see the cortisol between the IVC and aldosterone, IVC and adrenal vein, IVC to left, IVC to right. So you can see that the right and left both are at least more than 5:1 ratio. Then we have to see the cortisol corrected aldosterone, cortisol corrected aldosterone of the right, of the left, and of the IVC. And here we have drawn that. Then compare the right to left. This is the lateralization index. This is less than, this is even less than 2. So this is clear-cut bilateral disease. And even the contralateral suppressive indexes can also be done. वो भी इसमें नहीं है. What is this? This is basically successful study. Both adrenal glands are source. So first, always assess cortisol values, and then this is the selective. Then the cortisol corrected aldosterone values, and compare the AC ratios on the right and on the left, both for lateralization index, and the low side with the IVC for contralateral suppressive index. Lateralization is when it is more than 4:1. Okay. So if we talk about this case, hypertension, hypokalemia, aldosterone was 20 and renin was suppressed. Confirmatory test was done, and the CT scan revealed basically a 7 millimeter lipid-rich lesion in the right adrenal gland, possible myolipoma. So AV sampling is done. Again, in the AV sampling here, you can see the aldosterone to cortisol ratio, 11, 1, 0.49. So if you compare right to left, right is 23 times more than the left. Okay. And right to left 11, 2.49. And then the contralateral selective suppressive index, the left one is very much low than the IVC. So CSI is 0.39. So right adrenalectomy done post-operatively, undetectable. But one important thing in the management after adrenalectomy is you have to confirm it, and then medications should be stopped. Mineralocorticoid receptor antagonists, other ACE, ARBs should be stopped because they cause hyperkalemia. Potassium supplements are stopped. And then you have to counsel the patient that hypertension will be improved but not resolved in all patients. You still would need 1 or 2 drugs for that because of the long-term vascular changes in these patients. Post-operative hypokalemia is resolved in all, and even the patient may develop post-operative hyperkalemia, especially when the contralateral suppressive index is less than 0.5. Treatment goal, control BP, but not just control of BP. You reverse the cardiovascular effects of hyperaldosteronism. You normalize the potassium and normalize the blood pressure. BP control is in around 30 to 60% of patients. If the patient is on 4 drugs, that may become control on 2 drugs. Long-standing hypertension will require antihypertensive therapy. Following excision, our patient had controlled BP on amlodipine only. So the mineralocorticoid medical treatment is basically we give mineralocorticoid receptor antagonist, eplerenone or spironolactone to reduce the CV effects of aldosterone. Non-suppressed renin is the goal, and normal potassium is the goal. Then, because of the increased ECF volume, thiazide works very well, and calcium channel blocker as a second drug. So this is to summarize primary aldosteronism, screening by Aldo, renin, confirmatory test done, then PA subtyping by AVS or by CT scan, whether it is APA or BHA. The treatment with MR antagonist, again, at the level of ENaC, this EMR you have antagonized, there will be no sodium reabsorption, and there will be decreased delivery of sodium over here, and this will result in volume contraction, and that can result in increase in renin. Again, same thing happens in adrenalectomy as well. So summary recommended therapies, you basically decrease the ENaC-mediated sodium reabsorption. That results in volume contraction, improvements in blood pressure, increase or normalization of the renin. Potassium and hydrogen also increase and normalize. Thank you so much.